starting this off today, first off, I'll introduce myself. And so I'm Morgan Price, and I'm one of the interim co-heads for the Department of Family Practice. And I've been working on developing this innovative support unit within the Department of Family Practice. I'm happy today to be co-presenting with Bob Willard, who is another one of our department members. And the topic we chose today to focus on is team composition, and then the features of highly functioning teams. This came out of some discussion both within the previous webinars, but also from requests from the community here as to topics that people wanted to explore. There's a clear desire to understand how teams are put together. And in that discussion, it's not just about team-based care and what roles you need, but then also how the people can work together to become a team. And so I thought having Bob come in and share some of his recent work that's local to the province around who are the highly functioning teams and why are they highly functioning was a good pairing for today's session. And this is our fourth of our series. We've got two more planned for the spring, one next month and one in June, and then debating whether we should take a little break over the summer and then kick it back off in September. But we'll send out a poll for that in the next month or so. So for today's conversation, wanted to talk about some of the literature that we've discovered around team composition in the context of that in medical homes, so in primary care and community care. Look at some of the work that we've started to find around how to estimate team composition. Understand along the way that team composition doesn't mean that you're a highly functioning team, and how do you move from team composition to a true team. And then Bob will come in and talk really about what are some of those features of highly functioning teams. So we've planned about half an hour of content or so, and please interrupt along the way. I'll do my best to watch the screen as well as I talk, but just jump in, unmute, and ask questions. And if we end up sort of presenting over the full hour with lots of discussion in between, or we do it as a condensed piece and then lots of questions afterwards, the idea is really to have that dialogue just like the last three times. All right, so my conflict of interest today is that I do work in a team-based community health center, and I think it's great. So I'm a proponent of this, and so I think that's really my biggest conflict. We're going to talk about composition. I have some very, very bad ways of estimating team composition, which might be helpful. And then going to talk about briefly about the need to continue to assess team function. And then that'll give us lots of time for Bob's section, and then time for discussion as well. All right. So let me dive into team compositions, and then I'm sure that's going to spur lots of discussion as people see some of this work. So for those of you who have just joined in, I see we're already at 25. Please feel free to interrupt as we go along. The purpose here is to have some discussion, and these are really sort of points to trigger discussion and thought, so jump in. So what's the right panel size? Let's start with a panel. I'm sure most people are familiar with that definition of a panel. That's how many patients can a provider or team support, and what's the right size? The answer to that question is like that, how long is a piece of string? The College of Family Physicians, we could turn to them for a reference here. They suggest a very narrow range from 1,200 to 5,000 patients per full-time MD. And the reason why that number at the bottom is so high is they actually cut that off arbitrarily, because they felt anything less than that, then you weren't truly a full-time MD. But there certainly are examples of people who have a smaller practice that's much more intense. Part of the challenge here is, what is the complexity of patients? What are the services provided? And I'll talk a bit about that. But interestingly, a recent survey in Canada looked at approximately half fit between the range of 1,200 and 1,800 patients in a panel. And this is not specific to team-based care. This is just what things are like in Canada. So that includes a bit of a mix. So for those of you who are familiar with the old about 2,500 patients per doctor, that's actually probably not based in a lot of science, and arguably is not a reasonable estimate outside of using a larger team. Are bigger panels better? Well, not necessarily. The studies have shown that if you increase your panel size up to a certain point, that ambulatory care sensitive conditions, that's the ACSC, hospitalizations will increase. And you actually want those, of course, to decrease. So if you have too many patients that you're managing, they're more likely to go to hospital. You're more likely to get outflows. So people going to walk-in clinics or other primary care providers to get some of their service because they're not able to get it within the team or within the clinic. And then if you look at things like chronic disease management, prevention and health promotion, those things aren't managed as well when panel sizes get too big. Interestingly, some studies have said it's a bit of a U-shaped curve. So if you don't have enough patients, you are actually not doing some of the management as well. And then there's a sweet spot in the middle for an appropriate panel size, somewhere in the 1,500-ish range. Was there a question there? No, okay, just an echo from outside. So the issue is, of course, we have more demand right now. So how do we increase our panel size without having those issues? And really the answer is why we're all here, which is team-based care. And many things can affect our panel size. I'm going to sort of highlight sort of the 5 areas here. At the top is our panel or our population that's being served. And really sort of in high-level buckets, the age, the medical complexity, socioeconomic status, those can all impact the effective or best panel size. So a simple, healthy group of people who are well able to self-manage and who are young, you can have many more of those patients than you could an elderly population, lots of complexity and less ability to self-manage. It depends on the services you provide. So if you are not providing a full suite of services, then it is possible to have a larger panel size. If you're being efficient and doing some of the advanced group visits and other kinds of aspects to practice, then you can have a larger panel size if you're being efficient in that manner. How the team works, that's a big part, and we'll talk a bit more about that along the way today. What is that breakdown of roles in the clinic? What are the activities that they do? And what are the individual provider skill sets? So if you have a group of people that are brand new to team-based care, they're going to be less efficient and effective than those who have engaged, gone through some CPD, worked together, and proactively working on improving the quality of care. The physical design of the clinic, the administrative support, how the tools like electronic medical records are used, those can all impact the ability to provide good care and then scale the panel size up a bit. And then we'll see in a couple of examples, policies and funding definitely can play a role in what are some of the options and what are the things that people are trying. I'm sure with this little picture, there's a bunch of ideas that have been missed, and I'll sort of open it out if people see there's big glaring things that should be highlighted in this consideration of panel size. I got them all? Okay, well then, we're moving along then. So let's,
Morgan, I would mention something that's kind of implicit here, but certainly as I'll mention comes out, is the role of relationships and how relationships get diluted with size. So it's just something to flash as an overarching issue that probably affects all of these squares.
Yeah, and Bob, that's a good point. I mean, there's a certain scale point where, what is a team and how is a team supporting an individual patient, and does that patient feel like they are the center of a relationship-based care model versus there's a bunch of random people that I go see when I need to, and that certainly that latter is not what we're talking about here. We're talking about being patient-centered and looking at that relationship and forming a team around a person, and then ultimately around a group of patients and population. But no, it's a good point to flag that's important.
Morgan, it's Sabrina. Can you hear me?
Hello, Sabrina. Yes, absolutely.
Hi.
Welcome.
I guess I would just comment that in terms of the population served, that there's also social complexity. So social complexity along with medical complexity equals like vulnerability. And so then of course, the multiple intersecting determinants of health will affect the ability of a team to provide care for a group of patients and individual patients in general.
Absolutely, absolutely. There's a lot of factors inside the population that can really change and impact what is an effective panel size.
I got one more.
Excellent. Ian, yes.
Hi. Continuity of care is, baked in here, but then I think in your EMR adoption little box, maybe information continuity is also a strong contributor to panel size, how well we can communicate.
Yeah, communication, and in communication within and without the clinic, right?
Yeah, and asynchronous and synchronously, and then all that kind of stuff. Yeah.
I'm going to need a bigger slide. But continuity is a key piece to this, and then relationship continuity as well as information for sure. Well, this is excellent. Anybody else want to add more to this? Okay, well, I'll move along. We can always jump back. That's not a problem at all. So with team composition, there's a couple of ways to start this. I'm going to say this a couple times today, but I think it needs to start with the need of the population. So this little illustration here is to look at the population to start with. And there's a number of ways to do this, but the one we've been thinking about is trying to break down some key groups, and then from there, look at what the goals are for those groups, and then try to estimate the specific types of services, what the needs are and what the tasks are. And then from those needs, you can drive out a team. And I'm going to loop back to that as a thought later on when I talk about the ways to estimate teams. Mapping those tasks to roles is sort of the next step that we've talked about and we think about. And there's a lot of roles. These aren't all of them by any stretch, but these are examples of members of a patient medical home or a primary care network that can be considered. And it ranges from the patient, their family, friends, and other volunteers, out more broadly than to community agencies that might be linked into the clinic or the medical home, and into some less different roles that are sort of less traditional, like behavioral coaches, health educators, navigators, and to many of the sort of more typical roles you'd think of in terms of office staff, mental health workers, dietitians, and I'm just picking at random here, pharmacy, nurse practitioner, and family doctor. The one I should have put on here, I just realized it wasn't on here, would be our specialty colleagues that often can come into one of these clinics and be part of the team.
Morgan, it's Louise.
Yes, Louise.
It may be worthwhile to differentiate roles from the actual health professional or provider, because roles will often relate to what services need to be provided to the patients. And so, for instance, a behavioral coach and an occupational therapist could do the same thing.
Yes.
Same with an NP and a family physician could provide some services that are similar. So it's sometimes the role is very much dictated by the professional, by the competency of that professional, and by the need of the patient and who's available when. So just to distinguish a little bit that term role and to tease it out a bit.
Yeah, and so Louise, what I've been doing is thinking of task in some sense. So prescribing or medication management is a task. And then a particular role like an NP or a family physician could manage that piece.
Yeah.
And there's obviously lots of overlap. And that's the other piece to highlight here is how you, in a particular team-based practice, break these down, those tasks and how they map to different roles, different provider roles. It's going to vary. And it'll vary for the person, and it'll vary for how the team is currently structured. And for some things in our clinic, the nurses are able to do a fair amount with medication within a certain defined scope. And in another clinic, that might not be the case at all.
Yeah, so really it's the role. Thank you.
Yeah. Yes.
Morgan, it's Christy.
Yes.
So I really appreciate you looking at tasks. I think we've had this conversation, and how I fear that we artificially get stuck on looking at tasks that fit a specific legalized or legal scope of practice, right? And you've mentioned that tasks can be accomplished by different, there's overlapping scope. But also, and you mentioned that teams will be constructed differently. And we also have to think of tasks that may be completed in contexts where there aren't all of these providers. So there may be local sort of groups that have not a formal provider per se, a nurse practitioner, a family doc, a physio, but they will then have certification or additional competencies that they rein in to support the needs of their community. So I really appreciate looking at tasks and then looking at who within that context, based on that community, can actually address those tasks, and not artificially limiting us in our thinking immediately to, oh, well, that would be a nurse practitioner, or, oh, that would be a pharmacist. So thank you.
Yeah. No, absolutely. I think there's also, and I haven't made it explicit here, but I will now, is that the team itself emergently can do things in a different way. I mean, that's partly why we're talking about this, but the scope of practice for a nurse changes when the nurse is working in a team, because there is the relationships amongst the team to provide consultation, backup, support, etc. Right? So an MOA standing out there on their own wouldn't do a lot of things, but in the context of a clinic, they're able to do things because of a level of connection and supervision and review. So I think that's absolutely another piece of this.
Morgan, it's Lee.
Yes, Lee.
Thank you. I just want to jump in as I look at this list. We have registered midwives are missing from the list.
You're absolutely right.
And in particular, with the rural obstetric work that's happening and the fragility of rural maternity, and the looking at team-based care around maternity care and well woman care, I think is really important.
Mm-hmm. Yeah, so corrected, done. I apologize. I pulled this list out of somewhere. And it was a merge of a couple of lists, so it definitely got missed, not intentionally.
Morgan, sorry to jump
sorry
in.
to engage in discussion, Sabrina. Come on in.
Yeah, so I think it's a really interesting discussion, and I wonder if a way to think about this is to think about what the core attributes of primary care are, and then to map the tasks, which you had in the slide before, to what those how those core attributes can be met in some way, to sort of get away from, because I can see what's happening is people are saying, that these professions we need to recognize what they do. And I really agree with what Louise said in terms of trying to decouple what legalized kind of scope of practice is, and then what the tasks are needed in order to create a patient medical home kind of environment. So, and I think that the sort of the core attributes of primary care in terms of continuity and coordination and access, maybe sort of a organizing framework to then start to organize some of the different tasks underneath, and then to think about, like, as you've pointed out in your slide before, how then you might then start to think about structuring what a team looks like inside a practice and sort of outside a practice. And I like to think about it in terms of ability to provide these services within a region. So I've been thinking about the divisions of family practice and how they work with different health authorities, and then how you could start to think about structuring the services to be available in a particular region versus thinking that each and every family practice may have the ability to have these kinds of people involved in their sort of internal practice.
Yeah.
I don't know if that's helpful, but
it is a good point. By having this massive list here, it does by no means suggest that all of these roles are under one roof. And in fact, if you go back to looking at the tasks, and actually we haven't broken those down, but as you break them down, you know, many of those tasks can be filled by many different roles. Some of them will be filled within the clinic, and the goal is with the medical home to do most of that. But there are going to be a lot that are done within the region and outside of the clinic, but still within the patient circle of care. I totally agree with that.
And Morgan, it's Christy.
Yeah.
I think we're getting that comment gets into the gray zone between patient's medical home and the primary care network.
Absolutely.
And so I think it's a great, I agree. There's sort of that we're starting, if we start at the practice level and we sort of evolve out, and then we're getting into the primary care networks and how all of the teams then relate to the service providers in the broader, you know. So I think it's great. I think it's all connected.
Yep. Absolutely. So let me jump through a few more, and I know Bob is looking at his watch as well. You know, this is the kind of discussion we want to have. So let's keep going. But Bob, don't worry, I'm going to make sure there's plenty of time for your slides. So team composition. So we've had this nice deep discussion here about team and the attributes of primary care, the tasks that spill from that can be filled by multiple roles. There's several examples out there. And I want to thank Susan for helping collect a few of these for me today to share. We'll start local in BC. So Prince George, they have a team-based care practice. And these are the roles that they've defined in their group. So family physicians, primary care nurses, mental health clinicians, social workers, physiotherapists, OT, and life skills workers. Now you're going to see that some of the names or the terms might be different, but they're likely serving a similar kind of role. Now, I just got a flash up saying that there's a group chat going on that I haven't seen. So I apologize if people are waiting patiently. Aha, Gray Scholler, I'm just going to jump back for a second to comment on compensation. Compensation broadly absolutely is a huge issue. We're going to talk about that. And then, unfortunately, Ron doesn't have a microphone or a camera. So so talking about some procedural services, that's absolutely a very good point too. I'm going to capture that for later and put it back in those slides. I'm hoping these slides become a piece of reference for people in the future as we revise them. So those comments are excellent. So Prince George has this mix, a lot of the traditional roles, plus this life skills worker. Going to the other side of the country, to Nova Scotia, here's an example of a team-based care practice that has a family physician, nurse practitioner, family practice nurse, one counselor, then the manager, and 4 MOAs. These ones are very sort of concrete in terms of the numbers, so you can see this that it's almost equal. Well, I guess it's 5 family physicians, 3 other providers, and then the administrative staff. Not clear in some of these exactly how much clinical work the MOAs do, but that can also be quite a variable amount.
Just a quick question. It's Goldis on the line.
Hi, Goldis.
Hi. In this practice, are all family physicians working full-time? Did you get a sense of that?
I believe that was full-time. I have to go back to dig in, but that was my understanding. If you want, I'll take that away to look for.
That'd be great. Thank you.
This one's quite different. So the Union Health Center in New York describes themselves as basically an ambulatory intensive care unit. And they support a smaller number of patients. I believe the number was about 9,700, but they have 140 staff. They're not all full-time. To go back to the other question, these are definitely not all full-time. In fact, a lot of the specialists are, they highlight that they've got 38 part-time specialists. And I don't know how part-time they are. the goal with this group is to really do an intensive engagement in the community to keep people out of hospital. And there's an awful lot of workflow management and care flow management for people. So it's quite a different model than the other two. I thought it was interesting to highlight this very large group. They're separated into floors, and you sort of, as a patient, you're part of a floor in the building, and your pod and your team are there to work with you. So you don't necessarily know that there's 140 other people, but you feel like you've got a bit more of a wraparound service around you that's a smaller group. But a very different model again. This one was able to do this, and I think here's the time to come back to compensation that Gray mentioned. Many of these team-based care practices, especially the smaller ones, start with fee-for-service providers. So family doctors and nurse practitioners, and then if they can, depending on the situation, physio would be another example. When you get into the roles that can't bill fee-for-service, I guess physician assistants do it, I believe, correct me if I'm wrong, but those are the roles that get added first, because it's scalable to a degree. Bringing on a nurse and paying a nurse salary without being able to bill back for it is often an impediment given the fee structures. So that's that one. Now going across the water further, now we're going over to the NHS. There's several examples there. Here's one. Very similar to Nova Scotia, a family doctor, 4 of them, a practice nurse, and then a nurse practitioner. So they have both of those. A healthcare assistant, which my understanding was a bit more of that navigator or perhaps a coach role. And then office staff that seemed a lot higher compared to some in Nova Scotia, but they appear to have a bit more of a clinical role, and they seem to do a lot more of the flow of documents and referrals and such. So those were some examples that I thought I would highlight here of team structures. They're not all that different than some of the things that people are thinking about in BC, with the exception of that huge one in New York. Here's my next part about how to estimate team composition, and there's huge caveats all over this, please. This is not meant to sort of translate into large, accurate estimates of service need, but just sort of to get the ball going. Before I dive into this, I see Sean's got a comment. In rural contexts, we often have a limited number of providers trying to fill multiple functional roles, sometimes with limited effectiveness, doing the best they can. Absolutely. Absolutely. I think we have that in different ways all across BC, in rural in particular, with the geographical distribution. Having heard this a couple times now, I am thinking that there's tasks and roles, and then maybe we want to go to provider as the third group and try to define roles less provider centric. I'll think about how to do that, because it definitely is coming back, isn't it? Of this difference between a professional role or I don't want to say non-professional. That sounds odd, but the person and their position versus the clinical role of prescriber, chronic disease manager, etc. Yes, in that other slide there was administrative roles. Absolutely, I had focused it down. So sorry, the question was, what about including administrative roles and education, etc. And in that one slide, I had some administrative staff in there. I didn't have not directly related to the flow of clinical care, so I'd taken out educators for CME. But certainly that could come back in. And we saw some papers around the role of learners in team-based care, which is a very, very important piece for us, obviously. So here's the model, pretty straightforward. No, okay, so in seriousness, there's about 4 models that I've sort of pulled out for discussion. So sorry, it's so hard to read body language when I don't have people in the room for bad jokes like that. So let's talk about these 4 different approaches, and you'll know that we're going to get to number 4 as the preferred but more complicated method. So fixed ratios, very simple. 1 nurse practitioner for every 5 doctors. That is very, very easy to calculate, and you're done. So the problem, of course, doing this, you can do a little bit of math with it if you want to make it even fancier. You can say, okay, we've got 4 doctors, panel size of about 1,200 people. We've got a nurse practitioner. Nurse practitioner is going to see about 600 patients. That gives us a total panel size of 5,400. Easy. You can stick that table into any proposal and you're done. The problem with this, though, is it doesn't reflect a whole bunch of things. It doesn't consider the specific needs. And it's also not likely to maximize the role. So in the case of nurse practitioners, it's a little easier because they tend to run their own practice. Just like adding another family doctor to a group of family doctors, it's fairly easy to say that it's, it's a bit of like and like. But adding in a physiotherapist or an occupational therapist or a chronic disease educator, it's very hard to see how much of that role you want just by the pure numbers. Expert opinion. I'm going to start my own clinic and I think you need to have 2 nurses for every 5 doctors and a nurse practitioner. Great. I think local experts will have a better understanding of the needs and bottlenecks, both within a particular practice population, if it's an existing practice that's being scaled and changed, and also the community. So, what services are working really well in the community and what need to be enhanced. And that's an important understanding too. So the context, and it goes to Christy's comment about that interface between the medical home and the network. That will be different in Prince George compared to Kelowna, compared to downtown Vancouver. The services wrapping around a team, you don't need to always backfill those, but if there's gaps, you do. So a local expert will know that. But it's still not likely an accurate reflection because it's based on sort of your own thoughts of what you think the needs are. You can do data-driven models based on current supply, and don't worry, the math doesn't get hard here, but you can certainly look at how many patients you're seeing right now and then extrapolate from there. So you can look at 10,000 patients, calculate their average visits per year. So you can calculate a visit demand per year. You can then look at how many visits per day each MD, each NP, and each RN will cover, and run the numbers out from there. It's getting a little bit better. The total visits, then you can extrapolate back, and you can see here with that group of family doctors, you can probably support that demand from the patients. The problem here, though, is that we're looking at current service. And current service doesn't always reflect true demand. So in our practice, we take care of, work with about 4,000 or so active patients, 4,500 active patients. And I think you can make a good argument if you looked at what we do that we don't meet the needs of those patients. So if you looked at what we were providing in terms of service, you're gonna underestimate, even if you readjust the team structure, you're going to underestimate the need. And that's where the 4th model comes in. And that's using patient need as the driver. So this is a very rough estimate here, but you can imagine what I'm going to show breaking it down by subgroups. And here's where you think of demand being the population care needs and supply being how the team intends to support them. And then, as I said, most primary care today doesn't meet the needs, especially if you consider things like health promotion and prevention, disease prevention. Okay, so as I said, huge grains of salt, lots of caveats, lots of disclaimers here, but let's think about it this way. If you look at a patient and think about what are their service needs over the course of a year, there's some models here from about 2012, looking at how many minutes of preventive care, how many minutes of chronic disease management, and how many minutes for acute issues on average for a patient. And here we look at about 120 minutes per year on average for a patient. And if you assume that one family physician or one full-time equivalent works a whopping 115,200 minutes per year, that could support a panel size of this complexity of about 1,000. Now we break that down into a team. And here's where the math gets interesting. If you're able to delegate some of those services across a team, then you can increase the panel size. So This first one I've already talked about, but if you consider that you can delegate a lot of the preventive services across a team, and this is, and I apologize, this research here was relatively physician-centric in the sense that it was delegating away from a family doctor, but these were the calculations that they showed. But here you can see with the high delegation model, we're getting closer to 1900. The medium amount of delegation about 1500, and the low down to about 13.5. With this, they didn't get down to the level of specific things. Like within chronic disease, there are many things that can be done, and chronic disease bundles in mental health as well as diabetes, etc. And those tasks for helping manage those are going to be different, and they may be completed by different people. So that hasn't been done. I haven't seen any good models about that yet. And we're going to try to dig into that as we go forward. And that's where we want to be. So we don't have that yet, but these give you an interesting idea of that generally prevention can be more broadly spread across a team. Some of the acute stuff probably can be, but in this model, they didn't talk about it, but the idea being that it would be less. And that can be a way to start thinking about team size as well. None of these are perfect, but they're a start for us. What we're hoping to do is sort of begin to populate this kind of worksheet for a population. So thinking about what's the general, the age-sex distribution for a population, and then what are some of the key subpopulations related to various things. I put a bunch in here related to chronic disease, maternity care, long-term care, palliative care. We need to add more there for sure, but those as examples. And then can we look at current service utilization and make some predictions about what the gap is? And then that can drive some of those discussions. We've only gotten as far as the mock-up. We've been talking with a few folks about how to start doing some of those calculations, but we're certainly not there yet. Okay, before I dive into this bold calculation, any thoughts or comments on the last section? Okay. So team composition that we've spent all the time talking about so far does not mean that teams are formed. And I think that's really important. It doesn't mean that you got the right people in the room, but you're not necessarily a team yet. So these things are important to consider. How do we springboard from a bunch of people in a room to a team? And that's going to require lots of work amongst members, continuing professional development, and ongoing work, both in terms of how the practice is performing, but also how the team is functioning. And then with that thought, I'm going to turn this over to Bob. And Bob, I'm going to stop sharing my screen and I'm going to hand it over to you. Are you still there, Bob?
I am, and I'm just in the process of sharing the screen.
Excellent. We got it. There we are.
And so I think given the time, what I maybe do is very quickly run through a couple of things that I think are relevant to the discussion that we've just had. And I suppose I might look at it that what we've had is a discussion about the anatomy of a team.
Yes.
And what we were exploring at the interprofessional team is more, I guess you might call it the physiology, or in some measures, of course, the pathology of teams as they are formed. What I would say in terms of transition, one of the teams or team arrangements that wasn't mentioned was the Southeast Alaska Indian health system. And very simply, they transformed. They had all of the stuff that we've talked about in terms of the way the teams are structured, and special teams for diabetes care, hypertension care, et cetera, et cetera. When the Aboriginal people themselves took it over, they transformed it completely on two principles. One, everybody would have their primary care, not their primary care that could be named and that they could see within 48 hours, or they could see somebody that would know them by name within 48 hours. And they transformed this system of 45,000 folks, cut their emergency use in half. which we've never been able to do in any way in primary care anywhere else in this country, and reduced references. So it was a nice natural experiment of the underlying importance of the idea of relationships as being foundational. And given that family practice is relationship-based care that endures over time and over place of care and over issue of care, there's a resonance with that. So as we move forward, and I'm going to have to précis a lot of things, but let me affirm that as with any relationship, and this cluster of relationships around it, everything is highly context specific. And that's what Morgan has made a very good point of. And some of the discussion earlier reinforced the context specificity of it. And the issue of tasks and roles is an interesting one, and to me is the interface between two views of the world. There's a view of the world that the world is a complicated place, that it follows some laws of physics or at least anthropology, and if we have a series of levers pulled with the right vigor by the right people, then we will get a predictable response. That's a complicated view, and it's fine for landing somebody on the moon. Complex views are more contextualized by raising a child. Anybody who has 2 children knows that the second one doesn't obey the laws of the first one. And that's because of the distinction between feedback loops and measurements. And so I think some of that discussion represents the confusion we all have between those 2 worldviews. And we try and have a conversation between administration and care delivery without recognizing that we're talking about 2 different worlds. And then we get into compensation and its influence, et cetera, et cetera. So let me just say that as by way of a transition, because in our exploration of team function, the primary interest was, as you'll see, how do you assess and more particularly encourage continuous quality improvement at the team level, not just at each team members, but at the team level. And when you think about context specificity, it's really helpful to know that oftentimes it's people outside the scientific realm that give us, our challenge. And as Thomas Pynchon said in Graviton's Rainbow, if they get you asking the wrong questions, the answers don't matter. And that leads back to me to this complicated approach, that there are many ways of asking many questions, but if we're asking the wrong questions or seeking the wrong answers, I think the way around that, I just want to make a quick case, is twofold. One is celebrate generalism, celebrate the fact that we're generalists. So as we explore teams, how they function at the present time, how they might be functioning better, it's important to recognize that no team is in isolation. As you'll see, the teams that we are studying are not just clinical delivery teams. They're the administrative teams. They are other, they are community-based evolving teams. So I won't have time to go into the details, but to simply say generalists keep the whole in part while attending to the individual parts, the system in mind when fixing the individual problems, and the end in mind when commencing the journey. And so our research methods and where we're getting is hopefully informed by that perspective as we move forward. Again, we are, as in the multi-professional healthcare team that I have the privilege of co-chairing with nurse practitioner Wendy Bowles from Fraser Health, is an interprofessional team and we worked through a detailed process of visioning, which basically was trying to get us at the point where we could have a common purpose. And I'll just flag that because we're going to come back to that when we talk about functional teams. So quality, do you know how I can get rid of this? Do I just minimize it?
We don't see it at all on the share. Don't worry about it.
Oh, you don't? Okay, great. So we define quality improvement, not just in the care of the patient, but at the organizational and systems levels. So to try and look at quality improvement at all of those levels requires a certain challenge. Okay, now it's not advancing for me. I am not sure.
You might need to click back on the slide. There you go.
Oh, okay. So I won't go into great details of a very extensive literature review, some of which would be reflected in some of the things that, that Morgan was saying. But as the group worked together, and this is an interprofessional group working together to try and define the realm, to try and assess the value of the literature review. And it distilled down, not surprisingly, into 6 interrelated pieces of any team that is going to be functional. So again, in the interest of time, I'll just say shared goals, clear roles, mutual trust, effective communication, measurable outcome, and leadership. What I would say is in each of those, for example, clear roles is not, as we got down to the physiology of how highly functional teams worked, is not what we discussed earlier in this program, and is a more complex thing. And I may, given the time, just have to very quickly rush to the end of things in order to do that. However, key to exploring how highly functional teams work is the idea of approaching it with appreciative inquiry. What we've seen demonstrated earlier is that very early on, the barriers to effective teamwork come up, usually monetary ones, and we waste a lot of time. In fact, it's interesting, I work around the world. I don't find anywhere outside of North America where compensation of the physicians becomes such a primary point of discussion early in virtually any discussion of systems reform. But, you know, if on the other hand, you recognize that no matter how dysfunctional a team or a system is, something is working in there, and use the process of appreciative inquiry. And again, I don't have time to go into it in great detail, but the slides will be available. And start a process of dreaming what might be, discovering what is, and cycling through a process of change. You do end up with a more effective understanding, not only of why the teams are functioning, but how they can be enhanced in their functioning. So we tried to look at, in our selection process, both emergent teams, that is newly formed teams, and those that were already created around particular issues or particular geographic areas. And we wanted to be reflective of both of those teams. What was mostly important, we wanted to look at those that were collectively competent. And again, we don't have time to go into the details of the tags that we used to show that. And we wanted to look at both the leadership of the team and the elements of competence that were embedded in the team. And then the elements of maintaining competence. How did the team define its competence? How did it address its competence? How did it embrace its commitment to continually improving that competence? And that's where the appreciative inquiry process was focused, with the idea that our work as a multi-professional team trying to effect change within the system was to then take that understanding and look for mechanisms for communication and engagement to then be facilitators of positive change. We had in our minds and are practicing to some extent the idea of using the epidemic model of systems change, of getting in, defining the elements of competence and with infectious enthusiasm, spreading those into others. So very quickly, we were able to spend 6 hours with the entire executive team of Northern Health. Comox Valley Perinatal Services were several years ago among the most dysfunctional in the province. They had transformed into being arguably one of the most functional perinatal services in the province. and we were able to explore the transformation. What was the transformation that took place in that? It was complex, of course, and maybe at another time we can get into a little more detail. And the Burnaby General Hospital. So we were trying to get sort of administrative team, a community arranged team, and a larger institution team to look at. And we had these research questions, which look intimidating, but in effect, they were able, what we were trying to do is tease apart. If those 6 jigsaw puzzle pieces fit together, and we explored with both key informant interviews and with focus groups in some detail, what was the meaning of those particular elements and how were they best demonstrated in their particular place. We end up with these kinds of questions because in a complex exploration by a generalist, you're not even in principle trying to look for the silver bullet. If we only get the payment system right, if we only get the administrative structure right, if we only get the organizational map right, then this is how it will do. So the research questions are collectively about keeping the whole in mind, but teasing out the parts in terms of how these teams function. What's the physiology of these teams and what seems to be relevant to them doing it? And so again, I'm going to just quickly flip through a lot of excellent analysis of the extensive discussions that we undertook with both key informants and with focus groups, and we did both in each instance, so that we had 2 usually complementary explorations. And what I'm going to do is just, given the time, I'm just going to come back to this briefly, and I would encourage you to look at it, because what it really tries to represent is not only the elements of an effective team, but the relationships that bind them. So that, as you see, the purple squares represent the individual receiving, and this, I apologize, I picked the wrong team. We've modified this to individuals receiving health services and health service providers. So it's much more inclusive, as well it should be, than this demonstrates, and I'll make sure that Morgan and the crew have the updated one. But again, it's recognizing that each of these elements needs to be thought of in terms of a relationship. So if we look at shared goal of patient-centered care, it's very clear, and Lee implied this, and somebody else implied this, participatory processes are absolutely essential. If we can't sit in isolation and decide what those needs are and what our goals are. Reciprocity, in terms of the mutual trust and relationship building, reciprocity was absolutely core in each of these instances. It wasn't missionaries going out to deliver babies in the Comox Valley. It was mothers in the Comox Valley working together with the professional systems to move it forward. Measurable outcomes, we tend to, in a complicated world, we tend to perseverate on that and say, well, we've got to have the measurements, what are the deliverables? Well, comprehensive evidence-based discovery and planning. And that's an ongoing process. That's a feedback loop, not a final destination. Clear roles and expectations, the effective and open communications, again, engagement of the community and provider, absolutely essential. And open, supportive, and visionary leadership required time as a real element. Some of the other stuff that came in, the measurable outcomes and timely feedback, it was very clear that flexible structures, trying to jam a service through some preordained evaluation matrix was actually counterproductive to making effective teams and allowing them to function. Open supportive visionary leadership was, again, featured not by just the charismatic leader, but the followership that was organized and was effectively evaluated. Shared goals involved intensely mutual understanding, making sure we were talking the same language, making sure that that those goals understood not only what our shared goal was, but why did we, as a nurse, as a doctor, as an administrator, why did we get up in the morning in order to undertake that task? And it was that deeper level of understanding that was essential in the functional team. And job satisfaction, absolutely essential. And as we see again, the axis between time on the one hand, job satisfaction, we have a culture of whining in Canada about how little time we have and how busy we are, and we don't take satisfaction that we might otherwise. So I just want to apologize for taking us right to the edge of the time, but maybe that's a bit of tantalizing, and I would love to hear from folks, or if there are opportunities to share more of the details of this. I think it would add greatly to any future discussions that that we want to have about team functions, not just team formats, but team functions, and how we address those. And I think we will be doing another round of other teams going forward. I would just close with saying, in terms of methodology, that I'm also involved on behalf of the Association of Faculties of Medicine of Canada in an appreciative inquiry using similar methodologies, looking at social accountability in the 17 medical schools. And that is also yielding some newer and different insights than the standard organizational model might. So thank you very much for your time.